will be my clinical approach to something like diarrhea? Okay. The first thing that you're going to look at is the duration. That is it. How long are the symptoms of the patient persisting for? If they are for less than 2 weeks, I will be pretty confident that this is an infective etiology, because less than 2 weeks means that this is an acute presentation. And acute presentation for something that has been a problem for over a decade, for example, a tumor, does that make sense? For example, I'm just exemplifying over here. Suppose the etiology is a VIPoma. It's a tumor of the GI tract. Due to that, some kind of a secretory part is there, and that is actually leading to my diarrhea. Do you think that the presentation will be as acute as less than 2 weeks? Suddenly the patient will get symptoms? Obviously not. Suppose the patient has some kind of a malabsorption syndrome. Do you think that the presentation will be acute? Whenever in medicine you have an acute setting of something, think that it might be an infective cause. Okay? Obviously, I'm not talking about acute myocardial infarction. Acute myocardial infarction does not have an infective cause. Obviously, that's common sense. But anything which can be caused by an infection, like diarrhea. So I'll think about an infection. Now, an infection can be what? An infection can be in the small intestine, or it can be in the large intestine. And we have just spent the last 10 minutes deciding whether it's a small intestinal diarrhea or whether it's a large intestinal diarrhea based on the symptoms that the patient presents us with. Small intestinal means it will be large volume, watery stools. There will be no abdominal pain as such. Frequency will be less. Tenesmus, blood and mucus won't be present. Tenesmus will be not present. All that, right? So if small intestinal is the cause, then viral etiology is something that I'll be mostly suspecting. It can also be something like a bacterial etiology, like enterotoxigenic E. coli. It can be cholera, Vibrio cholerae. And if this is the case, then mostly these are self-limiting. Which is why most diarrhea, and this is the most common presentation as well, most people that present with diarrhea have a problem for like 3 or 4 days, and then it goes away. No problem as such. This is the most common presentation of diarrhea. Done. It is self-limiting. It is a nuisance syndrome. Large intestine, on the other hand, you will get like fever, pain abdomen, blood, mucus, all that. This is caused by invasive organisms. Remember, we are only talking about acute infections. Large intestinal diarrhea can also be due to what? It can also be due to inflammation. Yes. Small intestinal diarrhea can also be due to malabsorption, osmotic diarrhea. We have seen this. But will it be an acute setting? No. It will be a chronic setting. We'll see it to that. So, large intestine, invasive organism. Like I've already said this. It can be Shigella. It can be something like non-typhoid Salmonella, or it can also be something like Campylobacter. Okay, sure, no problem. So this is the acute setting. Now, just like that, if the symptoms have been persisting for more than 4 weeks, it is a chronic setting. We know this. If it is chronic, then again you will see whether the problem is in the small intestine or is it the large intestine. If the problem is in the small intestine, how will you decide if it's in the small intestine? Again, the symptoms will tell you. Watery diarrhea, frequency is less, abdominal pain is not there, blood and mucus is not there, large volumes, all that is pointing to a small intestine. If that is small intestine, in a chronic setting, it cannot be simply an infection. It will be something else, like osmotic diarrhea. Osmotic diarrhea. And we have already seen that osmotic diarrhea, how will you find out whether it's osmotic diarrhea or not? So I'll need to find out if it's malabsorption or not. So firstly, the stool osmotic gap will be increased. We have seen this. Stool osmotic gap is increased in this, and this will actually improve on fasting. Improve on fasting. And we have already seen as to why that is. Osmotic diarrhea is due to malabsorption. The fats in my, mostly due to fat malabsorption. The fat in my food is not getting absorbed properly. So the fats, what they'll do, calorie dense nutrient, it will draw in water from my tract, gastric tract, and this will rush towards my large intestine. It will move through the entire gut, and then it will be excreted as pale, greasy, bulky stools, which is called steatorrhea. Classical presentation of osmotic diarrhea. What is stool osmotic gap? We have already seen to this. It is the measured osmolality minus the calculated osmolality of the stool. Measured osmolality, will it be high? Yes, it will be high. Why? Because I have calorie dense, osmotically active fats in my stool, and I'm excreting a lot of fat. So osmotically dense stool. So the measured osmolality will be high minus the calculated osmolality, which will be normal. So the difference will be high. So the stool osmotic gap is high. This is all revision, by the way. So I am hoping and praying that you're all getting this and not just zooming around. All this is not just zooming around your head. And we also know that since if we fast, no more fat in our food because we are not eating any food. So this all problem was due to fat being in my food, steatorrhea. So now no fat, or I'm not even eating anything. So my symptoms will improve. But my symptoms will not improve if this was either an infective etiology or if it was secretory diarrhea. We know that secretory diarrhea can be due to an infection as well, as we have seen over here, these things. But secretory diarrhea can also be due to, like I've said, a tumor, VIPoma. Okay. Now, if it is a large intestine and it is chronic, then again, it's not an infection. What can it be? It is inflammation. And what kind of inflammation? It is IBD, inflammatory bowel disease, or ulcerative colitis. This is the clinical approach to diarrhea.